Today's episode is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. This is AI-powered ambient technology that helps physicians be more efficient and reduce clinical documentation burden. We have a lot of that, Kristen.
Sure do.
To learn more about how the DAX Copilot can help reduce burnout and restore the joy of practicing medicine, we got to restore that joy. Stick around after the episode or visit nuance.com/discover-DAX. That's nuance.com/discover-DAX. Knock, knock. Hi. Hello, everybody. Welcome to Knock, Knock, I, with me, your host, Dr. Glaucom Flecken. Thank you for joining me here at your one-stop shop for eyeball things. You want to learn about some eyeballs today? Do you want to learn about some eyeballs today? I've been talking all day. Friday is I'm recording this on a Friday evening. I've had a long week of doing eyeball stuff. I'm not ready for it to end yet. I'm kind of ready for it to end, but I'm willing to keep it going for you all. Friday is my big clinic day, and I'll be honest, like I was struggling a little bit today. I'm a little bit tired. A lot of other things going on, and it was one of those days you just kind of got to get through. Like I like clinic. There's a reason I chose ophthalmology. Because I'm not a hospital medicine person. I like knowing that there's going to be an end to my day. So I'm more a clinic kind of person. People are either a hospital person or you're a clinic person. Or if you're a weird internal medicine person, you're a clinic and a hospital person. But for me, it's always been clinic. But today, I just had to like grit my teeth and just get through it. There are some days, and this is okay, even as a physician, where you just don't want to talk to people. You're done. You're done talking to people. But patients, sometimes they come a long way. They've been waiting to see you. They have eye problems. And so you got to put forth your best effort, even if you're not feeling it. Today, I wasn't feeling it, but we did it. Practiced some good ophthalmology. Took care of my patients, and I'll tell you, I was ready to come home at the end of today. So, and now this is less stress. I just get to have fun talking to you all, teaching you a thing or two about eyeballs. I've been thinking a lot about the medical year. I've talked about this before. I don't know. I talk about things in all different places, but the new interns, the new first year residents, the new second year residents, new third year residents, everybody's starting a new year, which means a new year of responsibilities. And social media is an interesting place if your algorithm is feeding you a lot of medical things, especially like Instagram, Twitter, X, whatever. And you start seeing the posts, the things from the interns, from the new residents who are taking on these responsibilities. They're starting to make mistakes. They're experiencing difficult things. Sometimes it's we have to do with patient care, medical decision making. Sometimes it's interpersonal relationships, something I love to make fun of in my videos. I've been seeing some posts about people being upset about being ridiculed by attendings, like interns, med students, kind of getting the brunt of some harsh words from their attendings. And it always sparks debate in the comments about, are we just too soft now that we can't deal with a little bit of adversity? Well, let's just, there's a line, okay? Like, let's be honest, like 30, 40 years ago, medicine was surprisingly even more toxic than it is now. Like I would say it's gotten a lot better over the years, but it was really bad. And it was people working 100-hour weeks, and they were grumpy, and they were mistreating each other, and just angry, and all the time. And they were competing with each other, and things have gotten better, but you still see people talk about, an attending that, kind of made me feel like I was dumb or I didn't. And a lot of these types of arguments between people have to do with like the idea of pimping. And how is it appropriate to assess knowledge in real time during rounds, during the workday? And I actually personally, I like when I was a trainee, a resident, I enjoyed having my attendings ask me questions. It put me on the spot, get me to explain my reasoning, get me to answer sometimes very obscure questions about eyeball stuff, embryology, things I don't know, zebra diagnoses. And yeah, it sucks to not know the answer, but it was a good learning experience because I think sometimes that little bit of shame, not a lot of shame, I wouldn't even call it shame, a little bit of like you feel like you're kind of dumb. It's a bit embarrassing to not know the answer because we're all perfectionists in medicine. It almost is like it forms this like long-term memory arc in your hippocampus that makes you remember it for the rest of your life. Like I still remember some of the things I got wrong just because I got them wrong and I felt so bad about myself. There's some pathology in there, I think, but anyway, I personally am totally fine. I think most of us are fine with the idea of quote unquote pimping or putting trainees on the spot. But like there's a line where you're passing the point of like education and entering into this area of like ridicule and inducing like a feeling of shame and just embarrassment that's just a little bit too much. And I think that's where there is a line. There's a line there, and it's just I see these arguments going back and forth. Pimping is good. Pimping is bad. Like, and this just speaks to the problem with social media. There's no nuance in these conversations online, which leads to all kinds of arguments. I think I like it personally. I would do it to med students who would rotate with me. And I think it's a way to learn, but you don't like do it to like put someone down, right? You don't you don't want to try to make them feel bad about not knowing the answer. Trust me, med students, trainees, they will do that to themselves. All right. You ask a question, they get it wrong. You don't have to like point out that they should know the right answer. Trust me, they know they should know the right answer. All right, they're going to be harder on themselves than you ever will as an attending, and it just comes across as bullying when an attending does it to a trainee. So just do the education, but you don't have to take it farther than that. Anyway, I've been seeing these arguments, these comments, and but it's an interesting time. And one thing I wanted to mention was the topic of complications. I've talked about this a couple times on this podcast, and probably on our other one as well. But I thought what I would do is tell you a story about my first complication that I had, like my first surgical complication. If you subscribe to our newsletter, which by the way you should, glockenflecken.com/newsletter, every month I write a story. Usually it's something about my life or just the brain thoughts I have. And this month I wrote a story about my first surgical complication. So the way ophthalmology surgery works, a lot of people always ask, like, how do you learn to operate on an eyeball? Like that seems hard to figure out, and then you're doing it on a person and you don't want to blind them. And well, the way we learn how to do eye surgery, microsurgery, using a microscope is stepwise. And this is how most surgery, I think, is learned. You take it one step at a time. You start with the easiest steps, like inserting a lens. We take our artificial lens, we fold it up. It comes folded, or you fold it yourself, and you insert it through a 2.5 millimeter incision, very small incision. So that's like the first thing you learn how to do with cataract surgery is just putting the new artificial lens into the eye. That's it. You'll do that like 50 times before you even try to do anything else. And then the next easiest step This is at least the way I learned how to do cataract surgery. Then you'll do that 50 to 100 times. Then the next easiest step. So it's all these steps, step by step by step, until you've mastered all the steps, and then you can do a full cataract surgery. So when I was a second-year resident, this is the year at Iowa where we do our first full cataract surgery. So I had done the stepwise thing. I'd done all these steps, and then I was ready to do like my first full case. And let me just tell you real quick, I know I've talked about this before, but the anatomy of the lens. Again, cataract surgery is removing the natural lens of the eye and replacing it with an artificial lens. So think of your peanut M&M. You have the capsule, which is the candy shell. You have the chocolate, which is the cortex. You have the peanut, which is the nucleus of the lens. 3 layers of the lens: capsule, cortex, nucleus. So in cataract surgery, you're opening up the capsule, but you're keeping the back end of it, the back of it, intact. So basically, you're opening up the top of the capsule, scooping out all the insides, the peanut, the cortex, the nucleus. You're scooping all that out, but you're leaving the rest of that candy shell intact. Well, guess what I did, friends? When I was doing my first cataract surgery with one of my attendings, I broke that capsule, which is what you don't want to do during cataract surgery. That's bad. It's just something you want to avoid, because then it prolongs the surgery and sets the patient up for potentially other complications. It's something that you can still be fine, right? It's not like a permanently blinding condition. Things like an infection in the eye, endophthalmitis, are magnitudes worse than breaking the capsule, but it's an avoidable mistake. It's also one that every single ophthalmologist on earth has made. Every ophthalmologist has made that mistake. But not every ophthalmologist makes that mistake the first time they're doing a full case. When you're trying to like build your own reputation as a resident, as an ophthalmologist, and then you go and screw up the first thing you try to do. So that was me. And the patient ended up doing fine. My confidence was in the tank, and I just felt awful. And then about a week later, I had the opportunity to do another cataract surgery came my way. And guess what? I broke the capsule on the next patient I did. 2 patients in a row. Over the course of 2 weeks, I broke that capsule. Both patients ended up okay, but still, they had a longer course. It was a surgical complication. And I was like, in my mind, I'm thinking, well, I guess I have to switch over to psychiatry now. Like, no one's going to let me do any kind of surgery. I'm sure there are psychiatrists that have skills, all right? But for the purpose of this explanation, like, you get what I'm saying. I was ready to just be like, oh, I guess that's it for me. I'm going to get tomorrow. I don't know how they kick people out of residency, but I'm going to find out. And that was probably the lowest I ever was during residency. I had those back-to-back, relatively minor complications, but still complications. I screwed up. I made a mistake. And then I did my 3rd case, which went perfectly. And my 4th case went perfectly. My next 100 cases went perfectly. But my confidence took a hit, and I had to build that back up. And one thing that helped me was, it was probably about a month later, that attending that I broke the capsule with, I passed him in the hall, and he stopped me, and he said, "You know what I did today?" I was like, "What'd you do?" He said, "I broke the capsule." And he had been an attending. He's like a 20, 30-year career. Like, he'd done 10,000 cases, and even he made that mistake. That did more to raise my confidence than anything. And I guess, I don't know what the point of this is, what I was talking about. Oh yeah, because, new trainees, new attendings, new everything. beginning of the medical year. You're going to make mistakes. All right. You're mistakes you probably haven't made before, but you got to keep going and you got to learn from them and you're going to be fine. You're going to be fine. All right. I was fine. I'm a great surgeon. But yeah, my first 2 cases, I screwed up. So anyway, I've been just thinking about that a lot lately with the beginning of the year. And, but you're all going to be fine. All right. So, what are we going to talk about? You know what? We'll take a short break. Come right back with some eyeball stuff here. All right. We are back. Before we get to our topic, which we're going to be talking about the iris a little bit more today. I've done some stuff. I'm trying real hard not to repeat myself on this podcast. So, but I realize I think some people are joining. Like I get new people that start listening to these eyeball episodes, and so they haven't heard some of this stuff. So I apologize to the people that may have heard me say some of these things before. But I don't know. It's fine, right? You can hear me tell the same anecdotes over and over again. I've been I hear that from my parents all the time. My mom has told the same stories to everybody like for decades, and we all still listen to them, and it's fine. So, love you, Mom. Okay, so we're gonna talk about the iris, but I was going through some comments. All right, so I want to start doing lots of comments here. By the way, if you're not a subscriber on the Glaucum Fleckens YouTube channel, go and do that because that's where I'm posting all of these on YouTube. So if you want to, the easiest way to like post your undying appreciation for my content, which I hope that's what you're wanting to do on YouTube, on the comment section, you can go to Glaucum Fleckens, the Glaucum Fleckens YouTube channel. So you can see my face while I'm talking and also post your review of the episodes or any questions you have or any suggestions for topics. So last week was I did a famous eyeball episode about Bono's glaucoma. So I just talked a lot about glaucoma. And we're going to get to the name of that. We might switch it from famous eyeballs to something else. But I had a couple interesting comments. One person was very upset that I said glaucoma is the simplest subspecialty. Now, I think you're misinterpreting what I'm saying. This person was respectful, but also just very upset, saying that they have very complicated glaucoma is very complicated. And I want to clarify what I said because I didn't say it's the simplest subspecialty. All right. I said the treatment, when you boil it down, the treatment of glaucoma, how you approach glaucoma itself is very simple because all you're trying to do is decrease the pressure. That's what I was saying. So in a way, when you think about glaucoma, and how to make glaucoma better or treat glaucoma, it is simple. All the treatments, all the lasers we do, all the surgeries, all the eye drops, the dozens of different treatments are all geared toward lowering the pressure. In that way, it is quite simple because that is your number one goal. You got to get that pressure down. It's simple. But it is very complicated in how you do that, right? Which patient do you do surgery on? What kind of laser do you do? What kind of eye drops do you do? Well, they're not responding to that eye drop. Do we have any other options? Oh, it looks like they have an allergy. We can't use that eye drop anymore. Let's use this other one. When do you do a combined surgery? What type of surgery do you do? What type of minimally invasive surgery? Or do you need a maximally invasive surgery? There are so many treatments and it is very complicated. But in the end, you got one goal. You're trying to get the pressure down. So thank you actually for Lindsay for giving me that comment so I could clarify that in case anybody else was upset with me calling glaucoma simple. It's simple in a different way. Let's see. What else? We got some. You guys liked hearing about the famous eyes. This I like this. I had a couple people that recommended Starry Eyes, Starry Eyes instead of famous eyes. I like it. It makes it's better. Starry Eyes because it's like it's the starry night or stars. It's a star and the eyes. I like it. It's good. So Starry Eyes. We're gonna go with Starry Eyes. I also got a question about coloboma. Who was that? At Sarah Willie 5765 said, I would love to hear you talk about colobomas. My daughter was born with large colobomas in both eyes, and you're super at explaining eyeball stuff. Oh, thank you. I'm trying to make eyeballs as interesting as possible. I can do that. Let's go over and this is actually good. This leads into our topic about irises because coloboma is an iris problem. Sorry if you hear my dog in the background. He's going nuts about something. Okay, so the one thing that made me want to like take out my brain and just put it somewhere for a while so I didn't have to think about anything for a while is embryology. It makes me want to gouge my eyes out. I am not an embryology. It was confusing to me. All the pharyngeal branches and the things and the neural plates and neural crest cells and ectoderm and endoderm. It makes me crazy. And so I barely understand embryology. And so I'm going to make this very simple. A coloboma is when you have a defect in a part of the eye, a part of the eye anatomy, and it's due to this embryonic fissure not being able to close properly. So to make the eye, you basically have cells that kind of go around in a circle and meet up on the other side. All right, forming your eyeball. Well, if those cells don't meet up on the other side, then you end up with a defect. And you can have a defect in the lens, you can have a defect in the retina, you can have a defect in the iris. Basically because all layers of the eye, they do this. They go around and they come together on the other side. Sometimes they don't come together on the other side. So you end up with what's called a coloboma. And this is really interesting because as we all know, the iris is a complete circle normally. Well, if you have a little defect, basically you get an iris that's not a circle. It's kind of like a keyhole. So you when you look at it, it looks like you would like an old timey, like a giant skeleton key. You put it in. It has that shape, so it's round at the top, and then it just kind of opens at the bottom. It doesn't come together at the bottom, so you end up with this thing called a coloboma. Now, most of the time, this can be associated with pretty severe congenital anomalies, chromosomal abnormalities. Sometimes it's just a kind of incidental thing and it doesn't cause other problems. And so you can just leave it. Patients just have this and they do okay. But if you don't have a fully functioning, fully formed iris, think about what it would be like, what it's like when you get your eyes dilated at the eye clinic. Your pupil's really big and you're really light sensitive. Imagine going out in the summertime right about now and you have dilated eyes. That's why we give people these super cool, very fancy disposable sunglasses to go home with. Because you're super light sensitive. Well, people have a coloboma. They have a big opening in the iris that can't constrict and get smaller. And so people are more light sensitive sometimes. And that can be fixed. There's actually a surgery. Believe it or not, we can go into the eye. We have these really long, fancy needles that are super straight. And then we can insert them in the eye. Obviously, there's a suture attached to it. Snag one side of the iris, go across that coloboma opening, snag the other side of the iris, come out of the eye, and we tie a knot inside the eye, closing that gap. You can actually close it. You can reform a normal circular looking iris using suture. It's pretty cool. So we'll do that for patients who are very light sensitive and to where it's pretty debilitating. If we don't have to, then we won't. But anyway, that's the basics of coloboma. And again, it's really interesting to see on exam. And it's one of those things, if you have a coloboma, If you have a medical problem and they start pulling in med students and residents to come look at you, you got something interesting. A coloboma would be one of those things. You are an interesting case, as we would say in medicine, if you have a coloboma. So congratulations, if that's the case. All right. So let's talk about a little bit more iris stuff. Heterochromia. Because we can do some starry eyes. Starry eyes with we're going to call it starry eyes. Do you like starry eyes? I think since two of you independently recommended this, I'm going to stick with it. Okay, our starry eyes are going to be celebrities with complete heterochromia. So heterochromia is two different colored irises. Now, this is heterochromia there's a spectrum of it. You can have complete heterochromia, where you have completely two separate colors, one brown, one green, or one blue. All right, two completely separate. But usually that's not the case. Usually heterochromia is partial heterochromia, where you just have part of the iris is a little bit of a different color. And then you can also have what's called central heterochromia, where it's just the middle part of the iris is a different color. So there's gradations to this. Some people do have the full, total, separate color heterochromia. So shout out to this random website I found called allaboutvision.com. I will say I did not verify that these celebrities have heterochromia, but I do know a couple of them are accurate because I've heard them before. So we'll go through some of these famous people that have heterochromia. And it's interesting because there's lots of different reasons why you would have two separate colored irises. Some people are born with it. You have congenital heterochromia. And one of those examples is a major league pitcher for the Washington National. Oh, actually, I'm not sure where he's pitching now, but he was on the Rangers for a while. I'm not sure. I don't follow baseball that closely. Max Scherzer, famous pitcher, has been pitching for a long time. He has really striking heterochromia because he has complete heterochromia. So I've seen him pitch on TV, and they always have a close-up of his face, and you can see one eye is very dark, the other eye is more light. So he has a light blue eye, and he has a dark brown eye. He is the perfect example of complete heterochromia. It's very striking, and it's usually in that case, there's a congenital component to it. So what happens? Why does a baby have congenital, like what happens there? Why does that occur? So when babies are born, most of them have blue or gray eyes. So they are not very dark. Most babies don't have lighter colored eyes. And they will darken up over time. I had one of my kids is like that, had lighter colored eyes, but then ended up being more like hazel, brown colored. And the reason for that is because what promotes melanocyte development in your eyes is your sympathetic nervous system. And that happens, over the first few months of life. So eyes will darken up as the sympathetic nervous system will promote the melanocyte development, and so the eyes will darken. If you have a lack of sympathetic input, all right, which can be for a number of different reasons. One of them would be like a congenital Horner syndrome, where you have loss of sympathetic input to one side, then that eye will not darken. It'll stay light. Those melanocytes won't develop, but the other side will. So you end up with this really stark heterochromia because this has happened since birth. So for someone like Max Scherzer, it's most likely that his light blue, his blue eye is the abnormal eye. Oh, sorry, the light blue eye is the abnormal eye because it didn't have the input to develop those melanocytes. Another celebrity with heterochromia is Mila Kunis. I've heard about this one as well. She has a different etiology for hers, and she has talked about this in interviews. A chronic iritis is a reason for hers. So iritis is inflammation in the eye, and when that happens, the eye doesn't like to have inflammation. It doesn't like to be inflamed. And so what'll happen is it'll start chafing off the pigment of your iris. And that's what makes your eyes dark brown, is you have a lot of pigment. You have a lot of melanocytes. Well, inflammation will start to slough that pigment off. You'll start losing that pigment. And that'll make your eyes a lighter color. It also causes other things like cataract. Inflammation just causes all kinds of problems in the eye, but it will give you a lighter colored iris. Here's another one I didn't know. Dan Aykroyd. He's always wearing sunglasses in like Blues Brothers skits and movies and stuff, but he has, I guess he doesn't wear sunglasses in Ghostbusters, but anyway, he has a brown eye and a green eye. I don't know. I'm learning all kinds of stuff here. Again, I don't know how accurate any of these things are. This website says that Idina Menzel, Olivia Wilde, Emilia Clarke all have that central heterochromia, where you have either maybe like a ring of hazel centrally, but then blue everywhere else, and then it's different from the other eye. So it's really interesting. Irises are, I mean, they're gorgeous. Like everybody. Which is why I'm about to get back on my soapbox, because I did see a post recently. Again, that same video I always see about the guy with dark brown eyes going in for a color change, an eye color change surgery. Ugh, I hate it so much. But anyway, you have beautiful eyes. Don't change your eye color. Don't be upset with your eyes. Like, oh my gosh. This is why whenever I examine eyes at the slit lamp, like I will frequently comment. No, it's not frequently, but I will comment. Oh, you have beautiful eyes. Your eyes are beautiful, gorgeous, absolutely stunning eyes. I'll say that not infrequently. I sound like an internist. Not infrequently. I will sometimes. No, I compliment people's eyes, because God, when you look, go online and Google image search. Slit lamp photo iris, and just look at the irises. It is so cool to see an iris up close like that in high magnification. The iris is so fascinating, and it's also a thing that you don't want things to go wrong with your iris. In fact, one of the surgical lessons that I was told by my residency program director at Iowa is you don't F with the iris, because you need your iris. You need that to be able to constrict that eye, that pupil down in bright light. You need it to dilate well in dark. And if you don't have that, then you get lots of like halos and light sensitivity and night blindness and all kinds of stuff. So you don't mess with the iris. Be glad that you have one. Because there are diseases like aniridia where you don't have an iris. And that's not an easy way to live. It's not an easy way to live. There have been times when I have been in surgery and I've accidentally effed with the iris. Sometimes you get what's called iris prolapse. Here's a way you can mess up the iris during surgery. So obviously when we do cataract surgery, we have to open up. I feel like I'm going all over the place in this episode. Sorry about that. But during cataract surgery, we have to dilate the pupil as widely as possible, because it's the lens that we have to get to do cataract surgery is behind the iris. So we can't have a small pupil, because then we can't get to the cataract. So we blast patients with dilating drops so that the pupil opens really. We give really strong ones, stronger ones than we give in clinic typically. So. And patients are sometimes dilated for like 24 straight hours after cataract surgery, which is an unfortunate thing. If I could develop a drop that will constrict pupils, I'd make a whole lot of money. We can do that, but not in the clinic. So anyway, we use drops to open up the pupil so we can do cataract surgery. Well, some patients don't have irises that dilate well. So if you're taking something called Flomax tamsulosin, which is an alpha antagonist, one of the alpha 1 blockers, one of the things. It's an alpha 1 thing. It's used for prostate, which is why I don't know anything about it. But I do know that it acts on the smooth muscle in the iris, and it prevents the iris from dilating. And sometimes when you're doing cataract surgery, you'll take your instrument out of the eye, and the iris will follow you out. It'll try to come out of the incision. That's called iris prolapse. And that is, by definition, effing with the iris. All right. And so you don't want that to happen. You have to try to push it back in. There's a variety of ways to doing that. But it causes chafing of the iris. You lose all that pigment on it. You get these what's called transillumination defects, where you're looking at the slit lamp and you actually see light through the iris. That's not a good thing. You don't want light coming in through the iris. It's the whole point of the iris is that you're able to use it as like treat it as an aperture of a camera, right? So don't mess with the iris. That's lots of things and you can have, I talked about inflammation affecting iris color. There's, things like, herpes simplex virus infection is a known, very common cause of having iris heterochromia. There's any number of things. We talked about Horner syndrome, but I won't get into. Let's see. Did I miss any? Oh, here's one. David Bowie doesn't actually have heterochromia. Huh. Oh yeah. He has anisocoria. Oh man, did I screw? No, I didn't talk about that, did I? In a prior episode? No, I didn't. I talked about. Oh, is that right? We did ptosis. I was for a second there. I was like panicking that I did an episode on Bowie because he was on my list. But that's right. He has anisocoria, which is just a difference in pupil size. Anisocoria. So he doesn't actually have heterochromia, but people think he has heterochromia. So anyway. Oh, and surgery, just having surgery on the eye. I mentioned that, right? Iris prolapse. Well, guess what? If you lose some of the pigment of the iris, then that iris is going to look like a different color. And there are certain medications as well that can also give you a difference in color of the iris. So, lots of different causes. I realized I didn't do don't do that eyeball tip of the week. I think maybe it's been a little while since I've actually done that. I feel like I've already done don't change your eye color. that might be don't. How about this? Like don't if you have either a surgical or a medical complication, don't panic and try to do something else with your career. Like you can still be a doctor. All right. So don't do that. Life tip of the week is don't overreact to your screw ups, to the things you do wrong. Don't overreact. In fact, when they happen, like feel it for just a bit. Like let yourself have a little cry if you need to. That's okay. I've been there. But then realize you're still good at what you do. You're there for a reason. You've worked hard to get to where you are, and you still belong. You still belong there. Don't overreact. It's gonna hurt. It's gonna hurt. It hurts to screw something up like that because people trust you with their vision, with their health, and you feel like you let them down. But guess what? The only way to avoid complications is just to not be a surgeon or not be a physician, whatever it is you do. So that is our episode for today. Thank you for joining me, and thank you for all the comments and suggestions. You can also email me, knockknockhi@human-content.com. I'd love to hear your thoughts or any suggestions you have for eyeball episodes. Again, I'm your host, Dr. Glockenflecken. Special thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Brook. Our editor and engineer is Jason Portiza. Our music is by Omer Benzvi. Don't you love? I love the music. I still love the music. My kids sing the music. Sometimes I sing the music to myself. I won't sing it today, though. Knock Knock High is a human content production. See you next time, everyone.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.